Happy to. Thanks for having me. So I'm a full-time palliative medicine consultant, and I have been for the past 16 years. I've worked in different places in Canada, including Alberta, and for the last 5 years in Ontario, where I'm the head of palliative medicine at Queen's University and the medical director of the palliative care programs in our region across a couple of hospitals. And I've had a recent 4-year term in the president track for our National Specialty Society, the Canadian Society of Palliative Care Physicians. And I mention that as it's relevant to my experience in the impacts of medical assistance in dying, legislation and policy on the practice of palliative medicine, because it was part of my role during my presidency term to be able to address the palliative medicine voice on this issue with government and at various parliamentary committees, as well as help develop our guidance documents around palliative care and medical assistance in dying.
Jersey has always had an enviable healthcare system, but there are currently vacancies over here. We've got it's recognised there's a bit of a shortage of GPs and also other medical professionals. And you insist that assisted dying, that it should not be part of medicine, I think is what you've said.
Exactly. Yeah. So I don't think you need a doctor to give you a lethal injection, but more importantly, the way that it impacts your role as a physician to have death delivered as if it's like a standard treatment undermines, the millennia of the role of doctors to help people live well, but it's not evidence-based practice, right? So in medicine, we develop research and we figure out like what's got the lowest side effects and the most benefit, and you have a progressive order of things that you try with least harm, most impact to more high-risk procedures when other things fail. But in the MAID regime, you can go from no treatment. Let's say you have a new diagnosis of rheumatoid arthritis. You're just meant to be informed of your options. So you would say, you can have, this anti-inflammatory, these biological medications, or you can have euthanasia, as if it's equal to all these other options. So we don't have this progression. Like, okay, if a patient came to me with a seizure, I would not offer them deep brain stimulation, a very invasive neurosurgical procedure for refractory seizures, because we haven't tried the basic things first that we know will work, and then you go up the ladder of things with increasing risk. The same with, I say, an example of osteoarthritis. So if a patient comes to me and says, I have this pain in my hip, it's osteoarthritis, I want my hip replaced, I would never do a referral to an orthopedic surgeon then and there because the patient asked me to. I would say, like, we have these standardized evidence-based treatments that we're going to try. This is the order. We're going to try these things. But now we're expected, the patient comes in and says, I want euthanasia. We're expected to say, okay, if that's your choice, and refer them or do it ourselves.
Which is it's not
completely
really
it undermines the entire role of medical expertise.
Sure, because medicine has undoubtedly improved over time in all areas, and yet we've been progressing and moving forward, and suddenly, bang, there's a different route you can go down, and it's finite, and that's the end of it. So you're never part of that progressive.
Right. Well, and what's really scary about what Canada has done, so Belgium and the Netherlands, who also allow euthanasia outside of people who are more at the end of life, let's say, like the track 2 patients, as they will be in your legislation. They require all treatment options to have been tried and failed. So it's like a last resort that a person's life is taken. But in Canada, and very similar to the way the Jersey legislation is worded, you just have to be informed of your options. You don't have to have tried anything. And so it can become, as we've said, kind of like the only treatment you have, which is completely dislodging the medical standard of care. And that's one of the reasons why I think it's so dangerous for this to be in medicine, because then it becomes something that we have to do for patients, and it replaces care. And it replaces care not only in the way it's being offered, as if it's just routine, like we said, but it's also taking away resources from the things that have been necessary, like palliative care and home care, to help people live well.
Well, Jersey could maybe make this stricter, so it's not going to happen.
Yeah. Canada said the exact same thing. We thought we have this concept of Canadian exceptionalism, that we would be different than Belgium and the Netherlands, and we were going to build these tall fences. It was going to be just for this. And look how quickly we've progressed well beyond where Belgium and the Netherlands went. And as I said, every country who's legalized it has expanded, and it's a logical progression of where you end up. And there's absolutely no way you can keep it restricted. Once you legalize it, you make it a medical treatment, it will be available for everyone over time. So I think people in Jersey should not be fooled.
Right.
You know, it's really, you need to be prepared. Is this where you want to go as a country? And how do you want to care for people at their most vulnerable? Because those are the people who are put at risk of wrongful death or premature death by this type of legislation, that there is no safeguard that can be put in place that we've seen in Canada and other countries that can prevent that.
Actually, GPs are there to make people better, but if you're taking them out of 60 hours of helping people get better to be focusing on one patient who wants to end their life, it seems unfathomable, really.
Well, there's a good qualitative study that came out last year in Canada looking at the moral distress palliative care clinicians are experiencing because we're spending more and more of our time facilitating and administrating the MAID process and dealing with that. And then it also impacts our ability to provide palliative care, right? As we've talked about, the lack of waiting period and all that good work that we usually do is being taken away, and then we're being forced to facilitate MAID. So people are leaving the practice. So
this
nurses,
is a really
social workers and physicians are all choosing to do other things than palliative care.
This raises another very interesting point, because there's been so much focus around the person who's come in to seek help from the medical practitioner and how they're feeling, whether it be in pain. It then comes around to some of their mental well-being as to how they can be supported when they have got pain, which they may well be physical pain. But you're now bringing into the question is the effect of this whole process on the medical professionals. And
absolutely, and we need to talk about that. Because there's a lot of conflict within teams. How did we get to this place so quickly? Like, just 5 years ago, we said it was just this very narrow end-of-life category with these strict rules, and all the rules have fallen away. Now it's basically a person could come to their doctor and say, I want this, I have diabetes, I don't want insulin, I want this. And so, as I said, it's undermining the practice of medicine, and that's really hard for many doctors, let alone the amount of time they're having to spend away from their own vocation, like in palliative care. So we have a definite loss of people who are willing to do palliative care, and I would worry that in Jersey it would be a problem if people not wanting to work in an assisted death regime like we're experiencing in Canada. It's very tough.
You said, are there any moves in Canada at the moment? Are people questioning government, saying, well, hang on a second, perhaps we need to reverse this legislation?
Yeah, so there's definitely been an outcry as more and more of these cases have finally been coming to the media, because the media was so biased for those first number of years to really be playing up those horror stories to really, promote why this is a good thing. And now people are sharing their stories. And so I think the Canadian public and health professionals are shocked at where we are. And as I said, people are not in favor of it that used to be. And there's been an outcrying of that to the government and to politicians. And because of that, the government's talking about pausing or delaying when the enactment of mental illness as a sole diagnosis is supposed to start in March. But they said they have indicated they are going ahead with it, just to be clear. But they've said, I think, in a response to the significant media pressure to say, well, we'll just delay it a few months to make sure the appropriate safeguards in place. But they've already said no additional safeguards are needed. So it's just a bit of a smoke and mirror thing, I think, for the government to say we're listening to you, but we're going to go ahead with it anyway. The Justice Minister has been very clear that they intend to go ahead with it. So because they want to, as I said, continue to make this available to children and for people with dementia. So I think we're going to continue to see it expand.
Just wonder where it goes.
Yeah.
Leonie, thank you very much for your time, because I know that from here you're going over to London and spending time with colleagues in Westminster, and then I think going up to Scotland as well, because what's important for people to understand is that the decisions that we make in Jersey actually could well have an impact on the rest of the British Isles. So your input, insights and experience, having lived with the change in law in Canada over the last 5-6 years, is invaluable, and I think that's really, really important, and thank you very much.
Yeah, thank you for having me. And I certainly hope Jersey chooses a different path than Canada for the sake of its society as a whole and the people that live here. Thanks.
Okay, thank you.